Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I'm going to be talking about HIV and AIDS. And as always, whenever you get done watching this YouTube lecture, you can access the free quiz that will test you on this content. So let's get started. HIV stands for Human Immunodeficiency Virus, while AIDS stands for Acquired Immunodeficiency Syndrome. Now, HIV is a virus that attacks the body's immune system, and it specifically loves to attack CD4 positive cells. And what this means is that it attacks cells that have a CD4 receptor on its surface. And a cell that it really loves to attack is called the helper T cell, because the helper T cell has a lot of these CD4 receptors on its surface, so it can easily just attack it. But it also attacks other cells with the CD4 receptors, such as macrophages, monocytes, and dendritic cells. Now, helper T cells are a type of white blood cell, and these cells are very vital in helping us fight infection. But what HIV does is that, in a sense, it hijacks this cell, and it causes it to produce more HIV. And then whenever it's done with it, it kills it. So over time, HIV strategically kills large numbers of these helper T cells. And whenever we drop the count of these cells, what happens is that that person is at high risk for infections that normally wouldn't hurt someone with a healthy immune system with a high number of helper T cells. So they start to develop what's called opportunistic infections or diseases. Now let's look at some quick facts about HIV/AIDS. So whenever a person becomes infected with this virus, they have HIV. And over time, this virus can transition into what we call AIDS. Therefore, HIV really occurs in stages. So a person becomes infected, they enter the acute stage, followed by the chronic stage, and then the last stage, which is the AIDS stage. And this is the stage that has the shortest life expectancy. Now today, there's no cure for AIDS, but however, there are antiretroviral therapy, ART, which is a combination of medications that patients with HIV can take, and this can help improve their counts, their CD4 count, their helper T cell count, which helps them keep infection off and helps improve their life and help them to live a lot longer. But now let's look at some statistics about HIV/AIDS. How many people have been infected with this virus since we have identified it, and how many people currently are living with it? Well, according to the World Health Organization, since the beginning of the epidemic, about 79.3 million people have been infected with the HIV virus, and 36.3 million people have died from HIV. Now, currently, the number of people who are living with the virus, WHO estimates that globally at the end of 2020, 37.7 million people were living with HIV. So how is HIV transmitted, and what increases your risk of becoming infected with this virus? Well, it really depends on several different factors. One factor is the viral load of that infected person. How much of that virus is actually in their blood? Because the higher amount, the more likely they can transmit it to others. For instance, during the acute stage of HIV, the person has a high viral load, so they have a lot of virus in the blood and they can easily transmit it. But if they're taking antiretroviral therapy, this can decrease their viral load and decrease the chances of them transmitting it to others. Another factor depends on the type of contact you've had with that person who has HIV, because certain activities increase the risk of transmitting the virus. For example, having unprotected sexual intercourse with someone with HIV increases the risk of transmitting the virus compared to a needle stick. And an interesting statistic by the CDC says that healthcare workers who are exposed to HIV-infected blood via a needle stick have a 0.23% chance of becoming infected. Next is the immune system of the person who's becoming potentially infected, because there is a small percentage of people who are actually immune to HIV. Now, in order for the virus to actually be transmitted, it has to be in a specific type of fluid, because otherwise it will die. So it needs to be in either blood, semen, vaginal fluid, or breast milk. And once in this fluid, it can easily enter the bloodstream either directly or indirectly, like via injury or a mucous membrane. And some activities that can increase the risk of transmitting HIV include unprotected sexual contact, drug use like needle sharing, or a contaminated blood product transfusion, a needle stick injury, or a contaminated needle for a piercing or tattoos, or even during pregnancy, and this can be pregnancy itself, the birthing process, or breast milk. So how is HIV not transmitted? Well, as I just pointed out, HIV is a weak virus without a host of fluid, so it needs to be in that fluid. So generally activities like hugging, closed mouth kissing, touching clothes or objects, tears, sweat, or saliva without blood in it, or insect bites, household items, touching those, coughing, sneezing are not going to transmit the virus. So now let's talk about the pathophysiology of HIV. What happens in the body when this virus gets in, attacks the cells? How does it replicate, multiply, and damage these cells, which leads to the destruction of the immune system? Well, to help us understand that, let's talk about the key players of the patho. First key player is HIV, the virus itself, along with its life cycle, and the CD4 positive cells. Mainly, I'm going to be concentrating on the helper T cell. So first, let's talk about the helper T cell. So this cell is a white blood cell that helps us fight infection, and it plays a huge role in our adaptive immune system, which gives us the ability to respond and protect ourselves from foreign invaders. Therefore, it gives us acquired immunity. So like a memory bank in a sense against foreign invaders. So whenever we see these foreign invaders, we're like, I've seen you before, I can deal with you, and you're not going to cause me harm. But if HIV is present in the body and it's had enough time to damage these cells that help give us that memory bank against those foreign invaders, we can easily be overtaken by those infections or diseases and develop what's called opportunistic infections or diseases. And this can be forms of cancer, it can be from bacteria, virus, or parasitic type organisms. And the development of an opportunistic disease is actually one of the criteria used to diagnose AIDS. Now, the reason we call these types of T cells the helper T cells is because they help the immune system fight infection. And how they do this is that they release cytokines. Now, cytokines are like chemical agents that send a message to the receptor site on a targeted cell to cause it to act in a certain way. Therefore, these cytokines actually help activate other types of T cells known as the cytotoxic T cells, and they help kill invaders. It also helps activate macrophages, which help eat invaders, and then it helps activate B cells, which help us produce antibodies in response to those invaders. So as you can see, this helper T cell plays a very important role in our immune system. But now let's look at the HIV virus itself and how it affects this helper T cell. Here I have a basic HIV virus, and beside of it is a helper T cell. Now, the HIV virus is a retrovirus. It cannot grow or multiply without a host cell. And the HIV virus loves cells that have a CD4 receptor on its surface, because the way it's designed, it can easily access that receptor. And once it accesses and attaches to that receptor, it gets inside the cell, then inside the nucleus, where it takes over the cell's function, and it causes that cell to produce more HIV. So once it's done producing the amount of HIV it wants to produce, it kills that cell, and then all that fresh new HIV goes and just repeats this cycle. So in order to do this, it has to be designed in a certain way. So let's look at the anatomy of the virus. The virus is surrounded by proteins, glycoproteins, and here you will see those glycoproteins. And the particular part I want you to pay attention to are these little knobs here, these little protein projections. This is known as GP120, glycoprotein 120, because this protein is essential in helping attach to this CD4 receptor. Once we've done that, the HIV virus can attack and enter the cell. Then on the inside of the cell, I like to think of it as its little suitcase, because HIV knows it's not going to stay like this. Its whole goal is to get in and fuse with this cell. So it just needs to bring along the basic supplies. And I want you to remember some things that it's going to bring along. 3 enzymes. These enzymes are very important in the life cycle of HIV. First enzyme is called reverse transcriptase. Second is integrase. And then the third one is protease. Also inside is a single strand of RNA. So now let's look at the life cycle of HIV and how it actually gets inside this cell. It integrates itself, it starts replication, assembly, budding, and then we get new mature HIV. So the first step is attachment. What happens is that these glycoproteins, specifically GP120, goes and attaches itself to the CD4 receptor on that cell's surface. Here we have a helper T. Whenever that happens, there's also binding of a co-receptor. This could either be CCR5 or CXCR4. Whenever that happens, HIV has gained entry into the cell. Now what it's going to do, the next step is fusion. It's going to fuse itself with this helper T cell. And whenever it does that, it's going to take its suitcase, as I called it earlier, its contents and just dump it inside the cell. Because the whole goal of what it's got to do is it's got to set up shop and take over that cell. So it has some things to do. Once this material is dumped in, we have our enzymes and we have our RNA. It knows that this RNA needs to turn into DNA, so it brought along an enzyme. We're going to have reverse transcription. That's the next step. So reverse transcriptase is going to turn that RNA into double-stranded DNA. This viral DNA now needs to integrate itself inside the cell's nucleus. So it moves to the nucleus, it gets inside, and now it releases another enzyme that it brought along called integrase. So here it sees the cell's DNA. So integrase allows the viral DNA that was created to integrate inside the cell's DNA. So now it's just taken over the cell and it can control the cell's function. So now the next step is to replicate. So we have replication, we have the creation of these long protein chains, RNA. They start to become assembled, our next step, and move up because it needs to get out of this cell. So it moves up towards the cell's surface, it starts to grow outward, and it's budding. That's our next step. And once budding is complete, it pops off. And whenever it pops off, we have maturity. And the new HIV material in there releases another enzyme called protease. And what that does is it takes those long chains of proteins and cuts them, makes them shorter. And then that helps with maturity of the HIV virus. Once this process has been completed to the HIV satisfaction, it will kill this cell, and then new HIV is going to go around, find new cells to infect, and this cycle happens over and over. Now, why do you want to be familiar with the life cycle of HIV? Well, in order to understand how antiretroviral therapy works for a patient who has HIV, you have to really have a basic understanding of this whole life cycle, because these medications, a patient takes a combination of them, will target certain parts of this life cycle, like the attachment step or the fusion step or the assembly step. And by targeting that, we're going to limit how much HIV can be created, hence in the blood. So whenever a patient starts taking ART, they want to do it as soon as possible. The earlier we can start, the better. And this leads me into the stages of HIV. So let's take a look at those. So with this, we're going to talk about the signs and symptoms that you could see in each stage along with the testing. So the first stage is the acute stage, and this is acute infection. And this begins about a couple of weeks to a month after becoming infected. The person can spread it to others, and their viral load is very high in the blood. So there's a lot of virus in the blood. Now, what signs and symptoms will they have during this stage? They tend to have flu-like symptoms, which could include GI upset, headache, aches in the body, rash, fever, fatigue, joint pain, sore throat, swollen lymph nodes. And many times the patient or even the healthcare provider may not connect that this may be HIV, and so they don't really order testing for the patient. Now with testing, there is not a test that is available at this time to show immediate infection. There must be a window period that passes, and this is the time when the person is infected to when a test can deliver a positive result, hence detects antibodies the body made against the virus. And this is known as seroconversion. So therefore, a person can have the virus in the body, get a negative test result because enough time hasn't passed for the test to come back positive. So the person can still transmit the virus, and if a person suspects they have HIV, they still need to abstain from activities that could transmit it until they have confirmation. So window periods can vary depending on the test. So let's look at the different types of tests. One test is the combination test, and this tests for the antigen and antibodies of HIV. The HIV antigen is P24, and it can show HIV as early as 2 weeks. Another type of test is the antibody HIV test, and this detects antibodies of HIV, and some types of these tests can give rapid results, and a person can self-test with these. Now, it doesn't detect as early as the test above, the combination test. Instead, it can show as early as 2.5 weeks. And then there's the nucleic acid test. This test assesses for the virus, hence its RNA genetic material. So it demonstrates the amount of virus in the blood, hence that viral load. Now this test can give the earliest results for HIV. It can detect HIV in some people as early as 10 days. But this test is not routinely ordered compared to the other ones unless the patient is high risk and showing signs and symptoms associated with HIV because the costs are high. Next is a CD4 count. Now the CD4 count doesn't tell a person if they have HIV or not. Instead, this is very helpful in monitoring a patient who does have HIV, looking at the helper T cells, because that is what this measures, and seeing how they are doing on medication therapy. So a normal count for this is about 500 to 1500 cells per millimeter, and anything less than 200 is not good. It shows that HIV is really progressing. It's progressing to AIDS, and there is a risk for the patient of developing opportunistic infections, because remember, these helper T cells are not there to help us fight infection. Their count is really low, so we're at risk for this. And during the acute stage, whenever the patient is found out to have HIV, they need to start antiretroviral therapy as soon as possible, because what this is going to do is going to help lower that viral load, lower the risk of transmitting it to others, and lower the risk of the patient developing OIs, those opportunistic infections. The next stage is the chronic infection stage, and sometimes this is referred to as the asymptomatic stage. With this, signs and symptoms tend to disappear and the viral load is lower, but the virus is still active. It's still replicating and destroying cells. During this stage, the person can still transmit HIV to others, but ARTs help lower this chance. And the CD4 count is going to be greater than 200, but to about 500. And no opportunistic infections should be present during this time. This stage ends and the patient progresses to the last stage whenever the viral load starts to increase. There's the appearance of signs and symptoms, and then the presence of opportunistic infections. So the last stage is the AIDS stage, and this is again acquired immunodeficiency syndrome. And in this stage, the immune system is destroyed by the virus, and the viral load is very, very high in these patients, and they can easily transmit it. And without medications during this time, the survival time is only a few years. So how is a patient diagnosed? What are some criteria used to diagnose them with AIDS? Well, you look at the CD4 count. If that CD4 count is less than 200, that could indicate that. or they have the presence of those opportunistic infections. And this leads me to the opportunistic infections and diseases that a patient who is progressing into the latter stages of HIV may experience. So I'm going to cover the main ones that you want to know for exams, like the viral, bacterial, protozoal, and cancerous. So the first type is a cancerous type, and here we're talking about Kaposi sarcoma. So this is mainly seen in people who have a decreased immune system and causes the small blood vessels to grow abnormally. So this is a form of cancer that can grow in various places like the lymph nodes, organs, mucous membranes, and it tends to present as dark purplish brown lesions. Here you can see it in the mouth, and this patient has AIDS and a CD4 count of less than 200, which again increases the risk of developing this. Also, if you look closely, you can see a white film on the lesion. This is another opportunistic infection called candidiasis. Next is viral type, and this can be caused by the cytomegalovirus. And this is a virus that when you actually put it under magnification, it will have what's called an owl eye appearance, like in this picture here. And this virus can cause multiple problems in the body, affect the lungs, brain, GI system, and eyes. For example, CMV can cause retinitis in patients with AIDS, and it can lead to blindness, so they need to make sure that they're getting their eyes checked. And here is an illustration of a lesion caused by CMV on the eye. Next is the Epstein-Barr virus, and this can cause oral hairy leukoplakia, and this presents as white patches with hair-like projections on the side of the tongue, as you can see here. And this is actually a hallmark finding in a patient in this stage of HIV because it's signaling that the immune system is being taken over and that this disease is progressing. The patient is also at risk for herpes simplex virus. This causes cold sores and genital herpes, and it really depends on if they have type 1 or type 2. But it doesn't tend to cause severe problems in people with a healthy immune system. Like, yes, they have some signs and symptoms, but not as severe as what can happen in AIDS, and it can actually lead to deadly infections and complications. Next is bacterial type. So some infections patients with advanced HIV are at risk for is like the Mycobacterium tuberculosis, so TB, and this is spread in the air and affects the lungs and other parts of the body like the brain. So you want to be watching out for signs and symptoms of night sweats, weight loss, trouble breathing, coughing. They can also be affected by Salmonella septicemia, and you get this from eating contaminated food or drinking water that has this bacteria in it. They won't be able to fight this off. And then there's also the Mycobacterium avium complex, and this is various types of Mycobacterium, and they are found in the environment that normally don't harm people with healthy immune systems, but it's at risk for a person who has a low CD4 count. And lastly, Streptococcus pneumoniae. This can cause a serious form of pneumonia. So as a nurse, you want to educate the patient that they should get the Pneumovax because this can actually help prevent them from getting it. Next type is fungal, such as candidiasis. And this actually happens in people who don't have AIDS, but whenever a person does have AIDS, it can be severe and be really hard to treat. And this can be found in various places such as the mouth, the vagina, and lungs. Next is coccidiomycosis, and these are fungal spores that are found in dry soils like in the southwest of the US, along with cryptococcosis, which can cause pneumonia and affect the neurosystem, and histoplasmosis, which is a lung infection that can also affect the neurosystem, and it's found in like bird and bat feces. And lastly, pneumocystis pneumonia, PCP, and this can cause a serious lung infection. And lastly, protozoal infections, and these are parasitic in type. One type is toxoplasmosis, and this is a parasitic infection that can be inhaled. It comes from either cat or bird feces, or it can be ingested from pork and red meat. It causes serious lung infections and can affect other structures of the body. Next is cryptosporidiosis, and this can cause serious GI problems. And then lastly, cystoisosporiasis, which comes from eating contaminated food or drinking contaminated water, and this causes serious serious GI problems. Now, what are some preventative measures that your patient can take to prevent these opportunistic infections when they're at risk? Well, we know that they have a weakened immune system. So let's remember the word weaken. W is for water consumed should be from treated sources. They don't want to drink water from an untreated source. Let's say they're outdoors hiking. They don't want to drink water from a river or a lake. Or if they're traveling abroad, they don't want to drink water from foreign sources. E is for eat foods that are not raw or unpasteurized. So they want to make sure that they're consuming foods that have been fully cooked to prevent those GI illnesses. A is for avoid risky activities such as sexual activities that could cause sexually transmitted infections or drug activities. K is for keep vaccinations up to date, like with the Pneumovax, which will help prevent pneumonia. E is for exposure to animal feces should be very limited, especially if they own birds or cats where they have to change out that feces. So they want to limit this or get someone else to do that for them because that puts them at risk for that toxoplasmosis. And then N is for they need to take their ARTs, their antiretroviral therapy, because this is going to help keep their immune system strong. Now let's talk about the nurse's role and treatment for HIV. So as a nurse, we play a huge role with screening patients, identifying who is at risk for HIV, because if we can help the patient identify if they are at risk, we can get them treatment sooner with ARTs, which can help improve their life, and we can help prevent transmission. So all we have to do is ask specific questions, and that can help tip us off if this patient needs a test or not. Plus, we can help with educating them about the disease, how to prevent transmission, about antiretroviral therapy, etc. And monitoring the patient, monitoring their labs, knowing what tests have to be ordered, what's normal, what's not, the progression of the disease, opportunistic infections, etc. So with screening, we want to know who's at risk. So who is at risk for HIV? Well, anyone who engages in activities that's going to put their bloodstream or mucous membranes into contact with the fluids that can transmit HIV. So you want to ask them questions that can help identify if they are engaging in high-risk activities. For example, ask about their sexual behavior. Are they sexually active? If so, how often? How many partners do they have? What barrier methods do they use? And if they've ever had a sexually transmitted infection, because that increases the risk of developing HIV. You also want to ask about if they use drugs. If they do use drugs, what type of drugs do they use? And do they use devices that they share with others to take the drugs? Because that increases the risk as well, especially if they're injecting drugs and sharing the needles. And you want to ask them if they've ever had a blood transfusion, because if they had before 1985, the screening of blood products for HIV is very low. So there is a chance that they could have it. Now let's say you do identify a patient who's at risk for HIV. Well, you want to let the physician know who will order HIV testing, and we will test the patient for HIV. You'll want to explain to the patient about the test, about the whole window period, etc. Now, the CDC recommends patients who are at high risk have yearly testing for HIV. Now, for patients who, let's say, aren't necessarily at risk, but they're the ages between 13 to 64, regardless of their risk factors, the CDC recommends that they at least be tested once during a routine health visit for HIV, because some people may have HIV and not know it and unknowingly spread it to others. Now let's say that you do have a patient who is high risk for HIV and they get tested, they're negative for HIV. Well, you want to provide them with some education on PrEP. PrEP is pre-exposure prophylaxis, and this prevents from becoming infected with HIV. And to use this, they must be HIV negative and engage in high risk activities. And some medications that are used for this are like Truvada and Descovy. So patients who do take this, they can have protection from getting HIV if they engage in sexual contact or injecting drugs. It can provide protection, but there is a higher percentage of prevention with sexual contact than injecting drugs with this. Next is PEP, and PEP stands for post-exposure prophylaxis, and this is taken after a potential exposure of HIV. So PrEP was taken before a potential exposure, this is taken after. And it has to be started within 72 hours of that exposure. And it's not for routine use, but emergencies. So it's used like in cases of sexual assault, needle sticks, etc. And it's a medication regimen that is taken for 28 days. And these medications include Truvada and Icentris, which is raltegravir, or Truvada and dolutegravir, which is Temvicay. Now, Temvicay is not for pregnant women or for women who could become pregnant because it could cause birth defects. Now, what education can you provide to a patient who does have HIV on how to prevent transmitting the virus to others? Well, remember, the virus is only spread in those certain body fluids we discussed earlier. So one thing you can educate them about is limiting activities that actually transmit the virus itself. So you really want to assess your patient's understanding and knowledge of how this is transmitted and ask them questions, because that's going to give you clues on where you should go with the education. And talk about preventative measures on if they are engaging in these activities on how to prevent the spread, and letting their partners know and their partners becoming tested as well. And then there's pregnancy. So if your patient has HIV and they do become pregnant, there is a chance that they can transmit that virus to their baby. And this could happen during the pregnancy, during the birthing process, or during the postpartum period in the breast milk. So they shouldn't breastfeed because they could transmit it in their breast milk, and they want to start antiretroviral therapy as soon as possible because this will help decrease the transmission of the virus to the baby. And interestingly, according to HIV.gov, if HIV medications are taken as prescribed during pregnancy and childbirth and given to the baby for 4 to 6 weeks after birth, there is a 1% chance or less the baby will develop HIV. So with that said, as a nurse, we play a vital role in helping educate pregnant patients who are HIV positive and how to possibly prevent the transmission of the virus to their baby with these medications. So let's take a look at the antiretroviral therapy. So antiretroviral therapy or treatment has a goal of limiting the ability of the virus to replicate by interfering with the parts of the HIV life cycle. And remember, we went over that in depth. So we're targeting specific parts of that life cycle. So whenever we do that, we're going to decrease the amount of virus in the blood, the viral load, and this happens usually within about 6 months. And it's going to help increase CD4 levels. We want it greater than 500 because this is going to help prevent those opportunistic infections. So while patients are receiving these treatments, they will have these CD4 numbers checked regularly to monitor treatment and to make sure that medication resistance isn't developing. Whenever a patient does start this treatment, they will take a combination of medications. They'll start out taking 3 meds from at least 2 drug classes. Now there's a total of about 6 drug classes, and they include attachment inhibitors, entry inhibitors, non-nucleoside reverse transcriptase inhibitors, nucleoside/nucleotide reverse transcriptase inhibitors, integrase inhibitors, and protease inhibitors. And if you notice, those words in those drug classes are very similar to the steps of the HIV life cycle. So first, let's talk about the attachment inhibitors. And just as their name says, they are going to inhibit the attachment step in the life cycle of HIV. So HIV cannot go down and attach to the CD4 receptor and engage those co-receptors. So we can't really have HIV getting access to that cell. And that's what that picture right there is representing. So here we're talking about the post-attachment inhibitors. They bind with the CD4 receptors and inhibit the glycoprotein GP120 from being able to activate itself and engage those co-receptors, which could either be CXCR4 or CCR5. And there's currently one medication like this, and it's called Trogarzo. And this is not a pill. It's given given IV form, and the patient will receive it every 2 weeks. Then we have the attachment inhibitors. So it works a little bit different, but overall it's going to stop the attachment of the HIV virus to those receptors. It's going to bind to the glycoprotein on HIV, which again was what? GP120, and it's going to inhibit it from engaging itself with the CD4 receptor. And a medication that does this is called Rukobia, and it comes in pill form. Next are entry inhibitors, and they are going to block HIV from being able to enter the cell either by messing with the co-receptor or blocking fusion. So chemokine receptor antagonists, CCR5 antagonists, is a group of drugs that block the co-receptor CCR5 on the cell so HIV can't engage the receptor and enter the cell. And a medication that does that is called Maraviroc, and it is given in pill form. Then we have fusion inhibitors, and they stop HIV from entering the cell because remember, the virus must fuse with the CD4 cell in order to enter, and then it dumps its viral material into the cell. So we're going to stop that fusion. And this includes enfuvirtide, which brand name is Fusion. So to help you remember if this is a fusion inhibitor, remember fusion, it's Fusion, and Fusion has Fuze, that sort of looks like fuse, and enfuvirtide has Fu, so it's a fusion inhibitor. Maybe that'll help you keep it straight. And these medications are injected in the sub-Q fat, so it's not a pill. Then we have the non-nucleoside reverse transcriptase inhibitors. Now, just as the name says, it is going to inhibit that enzyme reverse transcriptase from working. And remember, what did that enzyme do? It was an enzyme that helped turn that viral RNA into viral DNA, which eventually is going to go into that nucleus of that cell and take over. So it stops the enzyme reverse transcriptase from working by binding to it. And an example of this medication is like doravirine. Then we have nucleoside or nucleotide reverse transcriptase inhibitors, and these are a little bit similar to the last ones we talked about, but they modify reverse transcriptase's role when it tries to convert viral RNA into viral DNA. And because of this, it will alter the development of how that viral DNA develops, so the virus really can't recreate itself. An example of this type of medication is abacavir. Then we have the class of integrase inhibitors, and just as their name says, they're going to inhibit the enzyme integrase from doing its role. And remember, what did integrase do? It allowed the viral DNA to integrate itself with the cell's DNA so it could take over that cell. So we're going to prevent that from happening, and it won't be able to insert itself. Now, to help you remember this class of drugs, remember the TEGRA in integrase, and their medication names have that in the middle of it. And one example, you've heard it before, is raltegravir. And then lastly, we have the protease inhibitors. And just as their name says, once again, it's going to inhibit protease from being able to cut those long chains of virus. So we're really not going to be able to allow that virus to mature. It can't really be assembled, so it can't go on and wreak havoc on the body. And an example of these medications is like atazanafir. And notice, these medications all end in NAVIR, so maybe that can help you keep that straight. Now, whenever you have a patient who is receiving this type of therapy, you want to educate them on some things. Number one, even though they have an undetectable viral load, because that's what these medications are supposed to do, they're supposed to decrease that viral load, it doesn't mean that they're cured from HIV or their blood's free from it. It just means that it's very low where we can't detect it. So they still want to take measures to prevent transmission. The risk of transmitting HIV when they have a really low undetectable viral load is slim, but they still want to take measures. And the medications, in order for them to work as they're prescribed, they have to take these medications exactly as prescribed. That means they can't skip doses, they have to take them at the same time every day. Why is this? Because if they don't do this, HIV's smart. It'll start a workaround of these medications. So we want to take them as exactly as prescribed because it helps keep the viral level low and it prevents drug resistance from developing, because if these medications aren't taken as prescribed, again, the HIV virus will get smart and they won't work anymore. So assess your patient's ability to take the medication. Will they have access to go get their medications? Do they have the money to afford these medications? And so forth. And then lastly, many of these medications interact with other medications. So as the nurse, you want to look at the patient's medication history, see what else they're taking, because a lot of patients, they take over-the-counter OTC medications, such as herbal medications to help them. One medication that a patient may take that's herbal is St. John's wort. This is used for depression, and this interferes with these medications. So as a nurse, we play a vital role with identifying that. Okay, so that wraps up this review over HIV and AIDS. And don't forget to take the free quiz that will test you on this content.